The broadcast is now starting. All attendees are in listen-only mode.
Hi everyone. I hope this is working for everyone and everyone can hear me okay. Is it possible for someone just to shout out a question, just to say yes, to make sure that this is working okay for you and that the volume's okay? Beautiful. Thanks, Sonia. So, nurse-led clinics. First of all, thank you so much for joining in today. I really appreciate that you've taken up your lunch break for most of you to participate in today. And I really appreciate that you're busy. So thank you so much. This is a two-part webinar. So we've got an hour today and then an hour again next week. Now I know that the webinar, how it's set up, it's not as interactive as what I'm used to. So what I'm hoping is that today, if you've got any questions that have come out of today's session, that you email them through to me. And what I'd like to do is to compile those questions, and then next week we can go through and answer some of those questions for you. So save them up, email them to me, then we can do a big answer of all your questions next week. Any questions that you have today or anything that's not working, just use the question box and just shoot me through something that's quite okay too. So let's get started. So the objective for today is simply to consider what's possible in your own workplace. I don't have a big list of objectives and learning outcomes, purely just consider what's possible in your own workplace. So again, any questions, either put them in the question box or you can email me at donna@cdprogramdevelopment.com.au, and then we'll go through all of those questions next week. So introduction. First of all, who am I and why am I talking to you today? So I'm Donna von Blankensee and I'm the CEO of CD Program Development. I'm a registered nurse. I went through uni, so I'm a uni nurse. Finished university, worked in a large public hospital in the south of Adelaide, and within my first week hated it. And I thought, I've just spent $15,000 on a university degree for a job that I'm really not liking. But I sat there and did that for a while. I was in the emergency department, and then I went to work in theatre as an anaesthetic nurse for a couple of years, so that was all good. And then I went into general practice and loved it. Found my feet and found where I was supposed to be in the whole nursing world, and I haven't looked back since. So I've completed a graduate certificate in chronic disease self-management through the Benchmark Group. I've also done the Certificate 4 in training and assessment and a diploma of management. And I've got no more study on the horizon at this point in time. As the CEO of CD Program Development, it's a company I started in 2011 after going to a dinner meeting. I sat next to a general practitioner and I was trying to make contact with him. And I said, "Oh, so do you do chronic disease management in your clinic?" And his reply was, "Nah." I said, "Oh, really?" He goes, "No, it's too hard, too complicated. I can't find a good nurse and Medicare's too complicated." And I said, "Oh, well, that's a shame." I said, "Look, if I could come to your practice on my day off and show you how simple it could be, would you have me come to your clinic?" And he said, "Sure, you can try that, love." So on my day off, I rocked up to his clinic and sat with his nurse, and we just chatted about chronic disease management and patients and Medicare. And I drove out that day and I thought, oh, if that's one GP, I'm sure there's other GPs that need help as well. And so about 3 months later, I quit my job as a clinical coordinator in a general practice and started this company. So since then, we work with general practices across Australia. So we work from practices that are one GP and one nurse to GPs, to clinics that have got 17 GPs on board. And we've worked with an organisation in New South Wales and Victoria that has 13 different sites, and each site has about 12 GPs. So I've worked with the small ones and the large ones. We've also worked with pharmaceutical companies. Often pharmaceutical companies will come to us and say, we want to do something in general practice and we want to be relevant, particularly around chronic disease management. So what can we do? We've worked with the old Medicare locals and the primary health networks to work with clinics and their staff around chronic disease management and health promotion. We've also working with SA Health to pull together some events. Silver Chain, they're in WA. I was fortunate enough to spend a couple of weeks in Walpole, which is, I'm sure you know where that is, down south. Loved it, fantastic place. And we're putting chronic disease management services into their rural and remote nurse-led clinics. Also working with Aboriginal medical services, and I've done some training for APNA and for registered training organisations, all centred around chronic disease management and health promotion. So the single GPs to the 12 site organisations, to the pharmaceutical companies, to APNA, to the Aboriginal medical services, they've all had the same questions when it comes around to chronic disease management and health promotion. And those questions are, who do we see and who do we target and what do we do with them? Where do we see them? When do we see them? And how many do we see? Why are we doing this? What's the point of it all? And how do we make this financially viable? So those questions, range differently in importance to the organisation. As you can imagine, some organisations simply go to the how can we make money doing this, but most of the organisations are, I don't know where to start. Who do I see? What do I do when I have them in my door? So it's those kinds of things. But they all share the same questions. How do we do it? How do we do chronic disease management? Now, I know that this is titled a nurse-led clinic, and it's a term that gets used a lot in primary healthcare. We're going to set up a nurse-led clinic. And I've often scratched my head and gone, well, what is a nurse-led clinic? So if I go purely to the dictionary, it's an outpatient clinic that is run or managed by registered nurses, usually nurse practitioners or clinical nurse specialists. So it's easy to say that nurse-led clinics gets talked about and it's something that we want to initiate. And I get it. I understand, being a nurse and wanting to empower the nursing people that I work with, that the more that we can lead and take charge of this, the better. But a lot of the literature I found around nurse-led clinics was all around cardiac outpatient clinics in big public hospitals. So there's not a lot of literature to be found about what a nurse-led clinic is in primary healthcare in general practice. So nurses are able to identify and manage aspects of care, typically in your hospital setting with your cardiac patients. So typically a nurse-led clinic in that is the patient going through their cardiac patients, managing them, running some outpatient clinics, which is all fantastic. But unfortunately, in general practice, that's not the arena that we work in. So in general practice, I often wonder about the term nurse-initiated clinic. So a verb, it's initiating treatment, or to begin, to set going, or to originate, or to initiate major social reforms. Now, I know I'm not trying to say that nurses aren't important or we can't lead. It's just that in general practice, the billing side of things comes from GPs seeing the patients. So a nurse-led clinic in general practice, if there was to be a nurse-led clinic where the GPs weren't seeing the patient, then there's less or fewer billing opportunities, and it's not something that's really going to take off in general practice. Whereas I think if a nurse-initiated clinic, if general practice nurses are in the position where they can initiate change, they can initiate patient management strategies, where they can initiate patient management programs to see better outcomes. So whether you call it a nurse-initiated clinic or a nurse-led clinic, the environment that we're working in is that we need to have the GP involved, and it can't be something that we do on our own, purely for billing and business reasons. I hope that comes across okay. Certainly not against nurse leadership. It's just in the context of general practice, we need the GPs to be involved in our patient management. Now, GPs attach an item number to most of the services that they do, and in order for them to claim those services, they need to see the patient. So I've worked with clinics where for a simple wound dressing, that their patients come in, the nurse has done a wound, and then gets quite offended that the GP then comes in, has a look at the wound, says it's okay, then off they go. And I try to remind nurses it's not that you're being double checked. It's not that your clinical expertise is being questioned. It's just that the system that we're working in, the GP needs to eyeball the patient, eyeball the wound to initiate the Medicare item number. It's unfortunate, and I think that we could do a lot of nursing activities without that, but that's the environment that we're working in. So it is what it is. So a nurse-led clinic or a nurse-initiated clinic, for me, the goal is to have a patient management program that the patients are benefiting at the other end. So whatever that's called. I hope that makes sense. So if we're going to look at our who, what, where, when, why of patient management, the first question always comes up is who do we see and who do we target? Now, as of 2014, over 23 million Australians, and we know statistically that half of those have at least one chronic condition. So there's a huge patient population in need of chronic disease management services. It's huge. And I won't bore you with the statistics of the disease types and the breakdowns and the how many's. There's just a lot. I think we all appreciate that in general practice. So we also know through statistics, and the reason I'm using 2013 and 14 is when I could get the data all to match for all the different variables. So in 2014, we had just over 24,000 registered general practitioners in Australia, but only 50% of those GPs were seeing less than 2 patients per week for chronic disease management. And I know I hear a lot of nurses and a lot of GPs saying, we're over-utilising the item numbers. We do too much chronic disease management. I'm going to get audited by Medicare if we do too many. But the reality is that 50% of GPs are seeing less than 2 patients per week for chronic disease management utilising the MBS item numbers, which is staggering. It's a lot of patients that aren't being seen. So who do we see and who do we target? It's really important to know that no 2 general practices are the same. In the single GP clinics to the multi-site clinics, I've never walked into a general practice that it has the same issues, the same staff, the same requirements, the same goals, the same outcomes, the same patient population. So from today's session and next week's session, you're not going to be able to walk away with the step-by-step A to Z process of how to do chronic disease management, because I don't know your patient population, I don't know your GPs, I don't know what you'll get at. So it's individual. So what I'm hoping that you'll get over today and next week is some ideas to rattle around in your brain to take back to the practice to, if we answer these questions, then this is the outcome we're going to get. And the outcome will be different for all of you, which is totally okay. No 2 general practices are the same. So their patient populations are different. The areas of expertise, their desired outcomes are different practice to practice. I haven't gone into 2 that are the same. So questions to ask of your own individual workplace is, who are your patient population? What is impacting your community or your region? And what are you good at? And what is it that you want to achieve? And those things will be different for each practice, whether it's small practice, large, Aboriginal medical service, a nurse-led clinic in Walpole. The answers to these questions are different. But what that does is it builds a program specific to your workplace, which is exciting. There is no cookie cutter approach to chronic disease management. It's what's happening in your workplace. That's the fun part. They're your patients. It's your skills, your expertise, your GP's desires and outcomes. So who do we see and who do we target? So the question to ask are, who are our patient population? So here, when I was employed as a practice nurse, I worked at a clinic in rural South Australia, and it was a very older population clinic. So our ladies in the clinic, the patients would often come in their court shoes and their stockings to come and see the doctor. Like, it was just very old school, very old community. The doctors had been there for a very long time, very old. Another clinic that I've worked with as a consultant is up in Golden Grove, which is a suburb north of Adelaide. And it was a very young population, so lots of babies and kids, lots of patients around that 40 to 45, 49-year-old age group. Now, there's the elder population, but a real young baby clinic. And so it was good to identify with these clinics, like, who are their population. So if we're looking at the older population clinic, doing a big pap smear, education event, an initiative, you're not going to get the huge patient population when a lot of the patients are a lot older. Same with asthma. The clinic up north with a young population, asthma was their thing. So going through their patient population, asthma was a disease state affecting their population. So the first question is, who are your patients? What do they look like? And what are the disease states that are prevalent in your clinic? So the elder clinic, osteoporosis and arthritis were a big deal. And obviously diabetes and heart disease. But in the younger population, it was asthma was their big disease state, and kidney disease. So again, who are your patients? What do they look like? And what's impacting your community or your region? I don't know if you notice or take notice that often there'll be National Heart Week, it'll be National Diabetes Week. So there'll be adverts played on the TV or on the radio around those times a year. So, you sit there and go, well, is this a disease state that's affecting our community or in our region? So how can we piggyback on all that media exposure, and you're looking at your primary health network, which is you've got the one in WA, what's their push, what's their drive, and is that lining up with what you're trying to achieve in your general practice in your local community? So what's going on around the place? With rural, there's always men's health is always important in the rural communities. Are they being looked at? With men's health, there's anxiety and depression, is this being treated? So it really comes back to what's happening in your community. I know in a clinic, I was working at the older population clinic, there was a tragic car accident of an older member in the community, which really impacted, the community was only quite small. So, patients were coming in and going, well, what am I going to do if something happens to my family? What things I need to put into place. So often with these smaller communities, if something happens, it's not that you take advantage of that situation, but it's like if there's, someone in the community has some big complication with diabetes, there's going to be talk around the town of what's happening with that disease state, or what's happening, with Mary. Mary lost her toe the other day to diabetes, and, they talk to each other. So it's like, if that's something in the small community that they're talking about, as a clinic, what can we do to address their concerns? So do we need to send out letters or talk or have posters in the waiting room around diabetes? So again, it's just what's happening in your area. So who do we see? Who do we target? Important question is, what are we good at? A lot of GPs will have a specific interest. So you'll have GPs that'll, think that they're the bee's knees or the answer to diabetes because they've gone to a couple of diabetes seminars and groups. So diabetes is their thing. They're all over it. Or you'll have GPs that, osteoporosis is their baby. They know everything there is to know about vitamin D and calcium and beta cross labs. So a good thing to start a chronic disease initiative is, what is it that your GPs are interested in? What is it that they're excited about? What can we take from their learnings to put into a patient chronic disease care plan? The nurses have specific interests. I know a lot of nurses do diabetes courses or asthma, COPD. So again, what are you good at? What is it that that you can put your skills and your expertise towards? Some clinics, I've put their health assessments question mark. Some clinics say that they are fantastic at doing health assessments. They've got a patient population that comes in, so it's great. Health assessments are your thing, so let's target a health assessment population, now 40 to 49s or our over 75s. So again, what are you good at? What is it that you want to do with that? And what do you want to achieve? So some clinics, they want to increase chronic disease management, or they want to increase their amount of health assessments that they do, or they want to be known as the diabetes, centre, or we do chronic obstructive pulmonary disease. So sometimes it's, what is it that you want to achieve? It's okay to have this idea that we want to do everything and be everything to everyone, but sometimes it's asking the questions to the GPs, to the ownership, to the nurses, whoever's involved. What do we want to do? What do you want to get out of this? So the first things are, who are our patient population? What's impacting our community? And what do we want to do with them? I hope that's making sense for you, but just simple questions to start asking. So an example might be, who is our patient population? You might have a whole bunch of diabetic patients, a lot of them. What's impacting our regional community? It might be men's health. So men's health might be important. What are we good at? We're actually really good at diabetes education. Our nurse has done a diabetes education course. The GP's all over it. So what is it we want to achieve? We want a diabetes clinic. We want to run a really great diabetes clinic. So great. There's your initiative. That's what you're aiming to do. You don't have to do everything to everyone, but you just start with, what are we good at? So it might be that you want to start up a diabetes clinic. So what is the desired outcome of this initiative? And do we have the resources to manage these patients? Which is always a really important question, is, do you have the resources to do it? Now, a lot of what I'm explaining today has come through a lot of trial and error, and I'm the first one to happily share my stories of failure, because I've learnt from them. And so here's a doozy, this one. So down at that Yankalilla clinic, where we had our older population, I said to the GPs and to the ownership, I want to do an osteoporosis screening activity. We were able to get the use of a DEXA machine from a pharmaceutical company. They said we could have it for 2 weeks. And so for 2 weeks, we could screen anyone eligible for osteoporosis. And I said, this is fantastic. I'm going to be screening everyone. So I had the pharmaceutical company, at their own expense, have this DEXA machine delivered to the clinic. They had technicians set it up, and there would be a technician there every day, all day, scanning patients. So it got to about a week before we're about to start, and I realised I hadn't actually sent out any invitation letters to any patients yet. I thought, no, that's okay. I'll get on the phone. As it turned out, we were ringing patients the day the machine was there, pretty much begging them to come in and have a DEXA scan. We were dragging people out of the waiting room to have this scan. And so instead of having this machine for 2 weeks, I think we barely lasted a week and we ran out of patients. And you've got to remember, this is an older population. We should have had plenty, but I just wasn't organised enough. So we had the machine, scanned our patients. The machine left early because I couldn't fill it. I couldn't utilise the equipment and the technician. And then all the reports started coming back, and it turned out that we had a lot of osteoporotic patients and a lot of osteopenic patients. And our GP was all over osteoporosis. That was his baby. And so we had decided as a clinic to put all our osteopenic patients on a care plan, because it fit the criteria that it was a chronic condition, was likely to last longer than 6 months, and these patients could benefit from intentional care. So then I had all these patients to contact and said, look, you've got to come in for a care plan. So they came in for a care plan, and I had no resources for them. I had very few flyers or information to give them. I didn't know much about osteoporosis. It was chalky bones. That's about all I could tell my patients. We had allied healthcare providers in the community, but this is a small community. So I'm sending everyone off to the dietitian for information about adequate calcium and vitamin D. I'm sending everyone off to the exercise physiologist for safe mobilising. I didn't want them falling and fracturing. And I was sending everyone else off to the occupational therapist for an assessment and for a home assessment. needless to say, these allied healthcare providers were calling me soon saying, can you stop with the referrals? I can't manage. This is a small community. I've already got my patient load. Now you're lumbering all these extra patients on and I can't see them all. So I had no allied health provider support. I had no education materials except what I was trying to print off on the internet. And I didn't know enough about osteoporosis to actually give them some quality information. So it was a big learning lesson. We actually went off and did that again a couple of months later. The pharmaceutical company convinced me to try again. So I had the DEXA unit again for another couple of weeks. But this time we were organised. I had spoken to the allied healthcare providers about which patients they wanted to see, what criteria they had to make it a worthwhile referral. I'd spoken to Osteoporosis Australia and had some really great resources. I'd gone to dinner meetings where they had rheumatologists speaking, endocrinologists speaking. So I got as much information I can about osteoporosis. So the second time around, it was much better, but I just didn't have the resources to manage them the first time round. The intention was good, but it didn't end well the first time, but we got better. So you kind of learnt from that and we moved on. So where do we see them? And I know this seems like a crazy question. It's like, of course, you just see them in the room. But how often do you have room availability to see patients? Now, some clinics have a lot of visiting allied health and specialists, so the nurse gets booted out of her chronic disease room. So you may only have access to a room, 2 days a week, or 2 half days, or 3 days. And so you have to weigh up, how often can we see these patients? How often can I see them? Do I have the time and the availability? And can you offer your patients privacy? I know some clinics who do their care plans in the treatment room, and it's the only room they have available, so they make it work. But if you're doing, a men's health initiative and you're going to be talking, about depression, anxiety, erectile dysfunction, can we offer these patients privacy? And how often do we have access to suitable space? So it's how often, if you are working in the treatment room and you want to screen it off to ask those difficult questions, how often can you do that? Are you able to do that at all? So it comes down to, where do we see them? Which is it's an often overlooked question, but sometimes it's those little ones that get missed. How often can we see them? Where do we see them? So this is to remind me to tell you of another couple of examples. Again, trial and error. The first one I've done myself, and then I've often asked clinics or asked nurses about this, and they've said, yep, exactly the same. So say I've gone off to another dinner meeting. I always go to the dinner meetings. It's a free meal. So I've gone off to my dinner meeting, and it's all about diabetes, and I've gone, that's it, I'm pumped. I'm going to see every diabetic patient we have in the clinic because I'm all over it now. So I've gone back to the clinic the next day, and I've printed off my list of diabetic patients, A to Z, and I've sent off my letters, and I'm calling the patients. So I'll call all my A patients. Usually I'll get to about B, C, maybe D if I'm lucky, and then I lose a little bit of interest, or I'm not getting the feedback that I need, or the patients aren't wanting to come in, so I'm kind of losing heart. So usually by about D or E, I've given up. I've just gone, nah, this diabetes thing's not working. My patients aren't coming in. It's not working. And so I've said to nurses at other clinics, who here, and you can answer this yourself, who started a big initiative, printed out your letters and started at A, and then usually get to E or F and lose a bit of steam. And mostly hands come up and go, yep, we've done that. So I always say, if you're a diabetic patient with the surname Abbott, you probably get routinely seen. But if you're a diabetic patient, or if you're a osteoporotic patient with a surname Z, then you probably don't get contacted all that often because they're still busy doing the A's, the diabetic A's, B's and C's and D's. So it comes down to a lot of patient population, and then we kind of just start at A. And sometimes it's just not the best way to do it. And other things I've done, similar scenario, is I've gone back to work and I've printed off letters, and I've printed off 100, 200 letters, and I've sent them all off in the mail. Again, best of intention, sent my recall letters off, or I've sent my invitation letters off to my diabetic patients. And it's usually not long later, but before the receptionists knock on the door and go, "Hey, have you sent some letters out?" And I'm like, "Yeah, I sent about 200 out." And they're like, "Stop." There's just an influx of calls coming into the reception area. And the receptionists are taking these calls, and all they've said is, "Oh, I've got a letter or something about diabetes." The receptionists don't know what I've sent. So they ended up taking telephone messages. I'm getting piles of messages that I have to ring back at the end of the day because I've just gone crazy and sent out so many letters. So again, these are things that I've done that just haven't worked. So again, it's taking those big numbers and make it into a smaller number as to what can we manage, or what can we send out, or who are we sending letters to. Because sometimes you can't do the A to Z, and you can't send out the 300, 200 letters. It's just not going to work. But that's okay. We have a solution for that. So we'll get to that one. So when do we see them, and how many can we see? So we need to take into account your staff availability, your room availability, and who is in most need. So say you said, yes, we're going to do our diabetic patients. We're going to contact them all, and we're going to be all over our diabetic patients, which is fantastic. Say that's 100 patients or 200 patients on your list, and you know that you've got the room 2 days a week. So, and it takes you half an hour or 40 minutes or an hour to do a care plan. If you send out your 100 letters, and goodness knows if they all were to reply back and say, "Okay, book me in," you're going to be booking up for weeks and weeks and weeks because you just don't have the room availability or the staff availability to manage sending out 200 letters. So then again, it's, okay, I've got my 200 patients here that I want to see, but I can only see them 2 days a week. So what I would suggest with diabetics is, okay, well then who's in most need of a care plan, or who's in most need of my attention right now? So what we often do with clinics is we'll say, well, let's print off the list, and through the clinical software or PenCat or Canning tool, we say, okay, who has a HbA1c of greater than 8? So now we may have taken our 200 patients and we've made them 80. You might go, look, 80 is a much better number that we can deal with. Or you might go, you know what, 80 is still a lot, and I don't know that we can see 80 in a good time frame. So then you might go, well, let's see who's got a HbA1c greater than 8.5 or a HbA1c greater than 9. So what you're doing is you're getting that 200 patients down to maybe 50 or 20. So it's those 20 patients or 50 patients that you send off letters to, or that you ring and call to invite them to come in for a care plan. Now, I'm not saying that the patients with a HbA1c of less than 8 aren't deserving. Not at all. If we had the time, the room, the staff, I'd say let's see them all. But take into account, if you don't have those things, then who are you going to invest your time with? So let's see those patients who are in the most need. So if a diabetic patient with a HbA1c greater than 9, it's probably important that he's seen more than the newly diagnosed diabetic patient with a HbA1c of 6.5. So again, it's what's your time, what's your availability, how many patients can you see, who are you going to see? So you could follow that with cardiac patients. I know using clinical software, if you do a search for heart disease, it gets a lot of patients with heart disease. So again, if you've got limited time, room, resources, you might say, well, who of our cardiac patients are on warfarin? So you might take a huge number and then bring that down a lot. So let's contact the patients who are on warfarin and get them in. Now, these are patients we want to know are being monitored regularly, that they're reminded about their leafy greens, and these are the ones that we want to know aren't taking a whole bunch of medications over the counter. So then you're being more selective, using the time you've got to see the patients that need your care. Asthma is another one. Asthma, if you do a data search for asthma patients, you get hundreds and hundreds of asthma patients. And a lot of that may be that they've come in, they're a bit sporty, and the GP has given them Ventolin and coded it as asthma. So again, if you want to see your asthma patients, let's use our clinical software to get those who've on a preventer and a reliever. Let's see what number that brings it down to. Or if that's still a huge number, who are those patients that have been on prednisolone? So if you've got an asthmatic patient who's on a preventer or a reliever and has had courses of prednisolone, they're probably more important to see those guys and get them managed than the 20-year-old who's had a Ventolin puffer once but just happens to be coded as asthmatic. So again, it's using your availability, your time, your resources to manage the patients that are in dire need of your help straight away. And again, for arthritis. See, arthritis is a big one. Lots of patients get coded with arthritis. So if you want to make that big arthritis list smaller, let's look at those arthritic patients who are on pain medication, or let's look at those arthritic patients that have got rheumatoid arthritis. So again, it's taking that big number and making it smaller, so you're seeing the patients that are in most need of your care and attention. Say you do that and you've got time left over, well then let's go to the asthma patients that have just preventers and relievers, or let's extend our cardiac patients to those who are on a certain class of medication, or our diabetic patients with a HbA1c of between 7 and 8. So it's not that those patients are left, it's let's prioritise the time that you have to see that the patients that you need to see. So I hope that makes sense. And I know when I've presented that before, nurses have gone, oh, but they're all deserving. And I absolutely agree. Every patient who is eligible for a care plan, I believe, should be on a care plan. But given your time and resources, who can you realistically see? Next. When do we see them? How many can we see? So who's in most need? So again, we're just reinforcing that limited time and availability, choosing patients with a higher HbA1c, if that's what we need to do to get through the patients. So I think one of the most important questions that we need to ask ourselves are, why are we doing this? Or what's the point? Now, my apologies if you've heard this already. I know some of you I've met at other training opportunities. But for me and this company that I set up, we have 3 non-negotiables when we're working with clinics. And that is any patient management program or any nurse-initiated clinic that we put together has 3 non-negotiables. And that is, it has to be good for the patient. It has to improve a patient outcome or has to improve a patient experience. It needs to increase the role of the nurse in general practice. The nurse needs to be on board, be liking her job, be enjoying the process of chronic disease management. And the third is that it needs to be good for the GP. And that is, we can deny it or not talk about it, but it's a business that these GPs are running, so it needs to have some financial benefits for the clinic. Now, at any time I say to nurses, if one of those is missing, then stop what you're doing, pencils down, and we need to reevaluate what we're doing. And at any time, if any initiative that we're doing isn't providing an improved patient outcome, then why are we doing this? It might be great for the nurse, and it's great that it's making money, but if the patients aren't benefiting, then why are we doing what we're doing? Same if you've got an unhappy nurse. If the nurse is doing a role that she's not happy with, she's not supported, she doesn't see the point, then we need to address that straight away, because you need a happy nurse, an engaged nurse doing this role. And financially, we can have great patient outcomes and the nurse is fantastic and they're all over it. But if it's costing the clinic money and it's running at a loss, well, that's not sustainable. So all 3, I believe, exist and they can exist together and they're all as important as each other. But they all need to be addressed. So you need an improved patient outcome. The GP needs to be happy and the nurse needs to be involved and engaged in the process. So it's doable. So what's the point? Now, in improved patient outcome, often GPs will say to me, well, because they can be quite stubborn, my apologies if there's any GPs listening in, But usually they'll say, well, I want proof. Well, where's the proof that this helps a patient? Where's the clinical studies to say that their HbA1c was reduced, or they were, they're better managed, or that their lipid controls improved, or their blood pressure's better? And I always say, there are the clinical indicators. So we did an audit from the clinic that we were working at after 2 years of doing this diabetes clinic. And after 2 years, the results were that HbA1c results or measurements were about the same. And there was an ever so slight reduction in blood pressure. Cholesterol was ever so slight. And it wasn't a robust clinical trial. It was just an in-house audit. And so we were all a bit disappointed, to be honest. We thought, well, we thought we'd see some significantly reduced HbA1cs in this. And one of the GPs said, well, that's true, but where would these patients have been had we not done a chronic disease program? What would their HbA1c and blood pressure and cholesterol be like if they had never had a care plan over the last 2 years? So while there was some indication of improvement, it wasn't huge, but it was there. Now, but what we did see was an improved medication compliance with patients, that patients who had had a good care plan and a nurse-initiated patient management, understood their medications better. The time they had spent with the nurse going through their medications, do you know what this is for? Do you know that you should be taking that on an empty tummy? That Panadol, Panamax, Febridol are all the same, so you can't be taking them all. So all those little things, and why they weren't taking their medication, so we could address those issues. So we could see definitely an improved medication compliance. The patients had an improved understanding of their own disease state. So patients who were diabetic could understand the difference between the HbA1c and a blood sugar level. They could understand the importance of a foot check and getting their eyes checked. They knew to, if they were feeling funny, to check their blood sugar level. Our insulin patients knew they had to be above 5 to drive their vehicle. So it's all these, they had a better understanding of their disease state, and they had a much better ability to self-manage. So patients who we had experienced on our care plan for that 2-year period knew that if they were not feeling well after a meal, or they were self-testing and they could see that their blood sugar levels were creeping up, were more inclined to make an appointment to see the GP or the nurse for the care plan review to discuss those things. They were able to understand with their warfarin, the importance of not eating all those leafy greens or to keeping it in balance, that if they went to the chemist to get all their fish oils and, St. John's wort and this, that, and the other, to check with the pharmacist and say, look, I'm on warfarin, is this okay? So they were much better able to manage their disease state, better understanding, improved medication compliance, and there was those clinical indicators that were slight but certainly improved with a care plan. So it was certainly an improved patient outcome. And we actually made a point of, asking our patients, you're coming in for a review of your care plan, how are you finding this? Or we sent out an invitation letter. Did the invitation letter make sense to you? Why is it that you're coming in for a care plan? Just to gauge their feedback, to make sure that it was something that they were interested in, that they're actually getting benefit out of, and done well. They loved it. So increase in the nurse role in general practice. I'm all for nurse leadership in general practice. When I started at that clinic in Yankalilla, I was the chronic disease nurse. All I did was care plans 5 days a week, 7 care plans a day, and loved it. But I got to a point where I thought, if I'm really running this, and I was really starting some nurse-initiated initiatives, the osteoporosis one, which didn't start well but ended okay, diabetes, COPD. So I went to the general manager of the practice and I said, look, I think, that I've got more of a leadership role here with this, and I want to be the clinical coordinator. And he said, what? I said, well, really, I think I'm doing a bang-up job, and I think I'm really bringing more to the table here, so I really want to negotiate, what my title is here and my financial reward? What does my pay reflect that increased leadership role I'm taking? So, that was after 2 years of being there, but it was like, so I understand that it's important for the nurse role in general practice to be recognised, certainly. I had a more proactive role in patient management. So we were, in consultation with the GPs, but we were really driving the patients that we're seeing. Who are we seeing them? Why are we seeing them? What does we want to achieve when they came in? And we were instrumental in the development of policies and procedures, or how patients were cared for through a care plan. So we really were instrumental in improved patient management. So our care plans started off as those generic ones that pretty much come with your software, to the point where we developed care plans that were more comprehensive, that included the diabetes cycle of care, and that all our care plans asked patients if they had ambulance cover, because often patients are never asked, do you have ambulance cover? Are you aware of the costs involved with ambulance transportation if you don't have ambulance cover? We asked our patients, our diabetic patients, our men, they were all asked about erectile dysfunction. I always firmly believe you're doing your patients a disservice if you don't ask. And yes, it can be a little bit embarrassing, but we as a clinic said, well, that's what we're going to do. We're going to, ask it in a sensitive way, but this is important. So it was part of our care plan. Obstructive sleep apnea. Now, obstructive sleep apnea is huge. Correlation between that and diabetic. So we had in our care plan to ask about sleep obstruction. Are you waking up tired? Do you wake up tired and you have little energy through the day? Is it increased eating? So if these indicators came up, then we're like, well, let's send you off for some sleep studies. Now, again, we knew who we could send those patients off for sleep studies, and we knew the allied healthcare providers who could provide that for us. But at least it was something that we could pick up and ask, are you doing this? Patients, are you aware that you should be above 5 to drive? And a lot of patients aren't aware of that. And now it's an old campaign that kind of just got lost in the wayside, but it's, checking with patients. Are you familiar with that? Do you have jelly beans in your car, in your handbag? And so often patients would pull out jelly beans and they were covered in bits of tissue and all sorts. So we'd give them a obviously clean specimen jar and say, let's pop some jelly beans in here, put them in the kitchen cupboard, in your handbag, in the glove box of the car, just to have these things around. So we designed a care plan or a template that was fantastic for our patients, that covered everything, that was in consultation with the GPs, but it was really nurse driven as to what is it we want in here. So I think it's important to increase the role of the nurse in general practice, definitely. And financial benefits. So a well-structured, well-run chronic disease initiative in general practice will increase revenue through Medicare billings for the participating GPs as well as the owners of a GP clinic. And it provides an ability to build a business model for future initiatives. So you've got a much better chance of going to a general manager or an owning GP and saying, well, look, can you invest some money or time or resources into doing a big COPD initiative? I'm going to need some patient education materials, or I really want to go off and do a COPD spirometry training course. I want to do these things. But if you can say, this is care planning, this is what I want to achieve out of it, this is what we think financial benefits will come in, this is how it worked last time, you're in a much better position to be able to negotiate those things when you know the financial business model for chronic disease management. And I know when I've spoken about chronic disease management and the financial revenues, that sometimes I get quite a bit of pushback from nurses saying that healthcare is not about the money. And I agree. I get that, but in general practice, we're working in a model that is driven by finance. A lot of smaller organisations, they have budgets, they have limits, there's a cap on what it is that they can spend. So if we can build a business model then we're in a much better position to increase those revenues and to build that onto other initiatives. So you can't separate the health from the financial benefits. As remembering my 3 non-negotiables, so good for the patient, good for the nurse, good for the GP/clinic. Clinics that we work with around building chronic disease programs, on average, our clinics increase revenue by about 105%, with a 0 increase in payroll costs. Is just by putting intention around chronic disease management and understanding the financial benefits. So that's a 105% increase on GP management plans and health assessment and the associated item numbers. And what we're doing, remembering we've got an improved patient outcome and the nurses are happy. So we're not looking at increased finances by annoying the nurse and having poor quality care. This is great quality care, happy nurses, happy GPs. So it's doable, all 3 of them at once. So how do we make this financially viable? Now, according to my phone, we've got about 5 minutes left-ish. So this whole financially viable, we go into item numbers and utilisation of item numbers and what's possible. Now, I had a look on the Rural Health West site of the webinars that are already there, and I know that there's a webinar there all about the item numbers for chronic disease management. So I'm not sure how much more you'd want me to go over specific item numbers. So what I was thinking is if we could brush over that today, just the item numbers that are available. And again, if I can urge you to email me any questions or specifics you have. And what we can do next week is look at a scenario. We could have like a fictitious patient clinic, and we could go through the how, what, where, when, whys of who are the patients, who are we targeting, what's impacting them, and then what we're going to do with them and follow that through. So if that's what you think is a good idea, please email me if you think that's how you'd like to go through those item numbers. I just don't want to be repeating all that same information again for you. And I looked at their webinar and I listened to it. And it's a fantastic one that's already on the Rural Health West website. So making it financially viable. Of interest, I think it was July 2005 that the Commonwealth Government introduced programs like the GP management plans and team care arrangements and the practice incentive payments. But if we remember back from our earlier slide, that there's 50% of GPs who are doing less than 2 chronic disease item numbers per week. So while the government's introduced these, they're still underutilised. And the government introduced them because they know or recognise that GPs need to be financially incentivised to provide chronic disease management care. But we're still not doing it very well. Talking to GPs about care plans, and like that gentleman I met at the dinner meeting when I said, what is it you don't like about it? And he said, it's too confusing, it's too hard, and I worry that I'm going to get audited. Most general practitioners, talking to them as to why they don't do this, it feels like I'm going to get caught, I'm going to get audited, I don't know how to do it well. And so a lot of getting over that is going, well, here's what Medicare says, this is what we can do, and then moving forward. I've found that GPs on the whole will err on the side of caution, and instead of billing what they think might be wrong, is they won't bill it at all. So it's interesting. They're incentivized to do it, but they don't do it out of fear of being caught for doing it. It's interesting. So the CDM numbers are for GPs to manage the healthcare needs of patients who have chronic or terminal medical conditions. And there's also item numbers to support various health assessments. And as you'd all be aware, there's no longer a health assessment for the Healthy Kids Check. That has gone. So it's your, your 40 to 49, 45 to 49, your over 75s. And then there's intellectual disability, refugee, defence force, so other bits and pieces along there. But the main ones are those 40 to 49, 45 to 49, and your over 75 health assessments, and all time-based. So how do we make this financially viable? It's linking in with the item numbers that are available. So whether that's a care plan, a team care arrangement, the nurse support item 10997, and there's others available if you're in Aboriginal medical services or supporting Aboriginal clients. Additional items, we're talking about ECG, Doppler, spirometry. A lot of clinics that we work with will see a patient for asthma or COPD, and then get the patient back for a spirometry. And so how we make this financially viable is getting the spirometry done during a care plan. So if you've got a care plan patient for an hour, you can do a pre and post within that care plan time. So it's kind of looking at what is it we're trying to achieve in this hour and what can we do. And again, the health assessments as lucking into what Medicare has to offer and taking advantage of what Medicare has to offer in a patient-centred way. So, but you do need to be aware that the requirements for those item numbers change regularly, and no one tells anyone until someone stumbles across it. So the link there is to frequently asked questions around the chronic disease item numbers. It's a huge document, and it breaks everything down a bit simpler, but it's important to keep abreast of the changes and what's happening with Medicare, especially for GPs and other billing practitioners. I want to know that we're doing what's right when it's happening for them. So a nurse-initiated clinic, success for a nurse-initiated clinic or for a chronic disease initiative or for a chronic disease program is intention. So the key to making anything viable is intention. What is it you're wanting to do? What do you want to get out of it? And being deliberate in who we're targeting, how we're going to target them, and what we're going to do with them. So success doesn't come from chucking out a whole bunch of invitation letters and hoping that they come back. It's got to be more deliberate and more intentional than that. So who are we targeting? What are we going to do with them? Where are we going to see them? When are we going to see them? What are we going to offer them? And what item numbers are we going to attach to that? It's all very doable, but it's never going to work if you're not deliberate and you're not intentional. Otherwise, it's just very reactionary care where you chuck a whole bunch of stuff out and hope that people react and come back and see you. And in my experience and across Australia in those 20 plus clinics that we're working with, it doesn't work. But intention and deliberate action will produce a much better outcome for any nurse-initiated clinic. So I think we'll leave it with that today. But I can ask you, please email me any questions that you have specific to that. And most importantly, if you want a scenario for next week, or we can actually walk through, go through the process step by step in a fictitious clinic. And also, if you've got any information or any questions about templates, I'm happy to share with you what our diabetes template looks like, for instance, how that works, and we can show you that. So it's designing a template specific to your community, to your region. So I'll leave you with that today, but email me anything and we can work that together next week to be able to come up with some answers and plans or whatever suitable to you guys. So if that's okay, I'll leave it at that for now, and we'll tune in again next week. Okay, bye.